So the purpose of this is really to give people a refresher, especially since if you're attending this, you've written a couple of treatment plans by now, probably a big handful. And so this is a really good time to get some refreshers and maybe answer some questions and work out some kinks so that we can make our service plans as amazing as possible. This is a really quick reminder. Our service plans are a direct product of our assessments, right? So when we assess a client, we determine what their needs are, what their strengths are, what their preferences are. We're figuring out why this person is receiving services with us or wants to receive services with us, and what the point of treatment with us is going to be. And so we can't develop a treatment plan, of course, until we've figured out what it is that the client is presenting with. Okay, so again, golden thread, you've heard me blab about that plenty of times, but just a reminder so that this stays really clear in our heads as we're talking about service planning, we're basically using the assessment to identify what the client's various needs are and what's going to benefit them the most. And then we're linking each of those needs into the treatment plan. We're saying, okay, so we've determined that the client needs these different things. Now, what are we going to do about it? And so depending on how complex this person's situation may be, the service plan may be really simple, or it could be really, really thorough and complicated. And of course, we're not going to bombard a client with a million issues to address all at the same time. So we're prioritizing. And in the assessment, we partly prioritize what needs to address in the treatment plan based on the severity risk ratings and the ASAM criteria, right? So if we determine that a person's level of severity is really, really high in dimension 3 and not very high at all in dimension 2, then it's going to be much more important that we're putting our time and attention into providing the client treatment services that address dimension 3 than it is that we, spend a bunch of time on dimension 2. So remember as we go along that the golden thread persists throughout, right? So whatever we're determining that the client needs in that assessment, we are responsible then for providing some sort of treatment for or plan for. Failing to do so would be like if a doctor conducted an x-ray, discovered 4 broken bones, but then only came up with a plan to resolve 2 of them. And they're just like, well, I don't know. I forgot about the other 2. The patient wasn't complaining about pain on those other 2. So we're just gonna not worry about it. Well, okay, maybe those other 2 broken bones don't need to be prioritized over the 2 that are causing pain, but the x-ray discovered all 4. So the treatment plan is going to need to address the fact that all 4 broken bones have been acknowledged, right? So when we are assessing a client, we're identifying then in the treatment plan whether we're going to treat, refer, or defer the different needs that the client presents with. And like I was saying, the risk ratings in the different dimensions kind of help you determine what needs are more severe and need to be prioritized over others. But this is also where client preference comes into play. So remember that treatment is for the client. This is the client's treatment plan. They're signing it. Hopefully they're participating in the development of it as well. And so we want to make sure that the client's signing on to something that they agree with and buy into. And so we are certainly wanting to ask the client their input on what they think is most compelling right now to them. What is it that they're wanting to work on right now versus what is something that right now they don't think needs to be prioritized as much. And so between our own clinical judgment from what we've learned in the assessment paired with the client's preferences, we can then proceed with identifying what we want to treat right now and what maybe we want to deal with a little bit later. But remember that regardless of what needs we end up deciding to treat right away, we do need to acknowledge all of the needs that were identified in the assessment. And as we know, each need that we're treating, we're going to write an objective to. Start with the focus need. And when we're looking at a client's long list of needs that we've identified in that assessment, we want to simplify things and just handpick about one need per dimension, assuming that this client has needs in all 6 dimensions. They may not, but let's say that they do for this purpose, then we would just be looking at what is the prioritized need out of each of these 6 dimensions for this client. And we're going to, oftentimes we'll refer to the first need that we pick as like the low-hanging fruit. We're going to pick something that's accessible to the client, that the client has buy-in to wanting to address, that the client wants to prioritize. And we're also going to make sure that our focus needs are, if there's anything that's a serious safety concern, that's going to be a focus need right now as well. We're prioritizing need based on safety and the client's preference. And ultimately, I mean, thereabouts, you'll have like about 6 objectives per service plan. The components of the service plan and how they are designed is so that we meet the requirements of both the Oregon Administrative Rules as well as CARF. If you find the format of treatment plans particularly daunting, overwhelming, distracting, it can be helpful instead to first just think about what you would want the objective to be outside of the format that it's written in. So instead of thinking about baseline measure and measurable outcome and intervention and blah, 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 start with just like, what is something that what is the focus need? And then what is it that we want to work on to address that need? Regardless of how you go about constructing your objective, when we plug it into this format, a couple of these criteria are really useful in then tracking progress moving forward. I really like baseline measures because they allow us to see where the client is coming from. And the second we have something concrete that we can point to and say, this is where the client is starting out, then it's a lot easier for us to then clarify what we want to see the client progress to. And when we know that, then we can determine how are we going to actually track this progress. So if we're looking at, where is this client currently at? Maybe it's something like that they can currently only identify one of their triggers, or currently they're only able to consistently cope with their triggers 50% of the time. What we want as specific and exact information as possible from the client. So if we're asking the client where are they currently at, instead of just kind of going off of like a random guess from the client, we want to narrow it down to get enough specificity around that baseline measure that it is something that will be able to then be built on. So if we're asking a client to share with us how they're currently doing with managing their triggers and coping with their triggers without resorting to use, something along the lines of like, I do fine, or, sometimes, that's such a vague and broad response then that makes it really difficult for us to gauge where they're really at, and also then what would it look like then when they're doing better, and how will we know that they're doing better? So that's where utilizing measures can be really, really useful, like actual measurement tools. And in fact, implementing structured measurement tools for certain kinds of objectives can be the best way to determine whether or not the person is making progress. A lot of you are familiar with Likert scales. A Likert scale is simply when you're asking somebody to rate something on a scale of like 1 to 5 or 1 to 10. It can be whatever range you want. It can be very unlikely to likely, or not concerned to extremely concerned. Anything like that is considered a Likert scale. Likert scales are one effective way to develop a baseline measure and then to measure a person's progress. The tricky thing about Likert scales is that a lot of us will try to force something into a Likert scale that doesn't make sense or can't really be measured by a Likert scale. What I mean by that is this. On a scale of 1 to 10, the client's current ability to cope is a 6. That is a Likert scale, but what is a 6? how do we say that a person's ability to cope is a 6? 6 what? 6 skills? 6 times a day? 6 out of 20? 6 out of 2? 6 out of, right? Like that doesn't actually mean anything without context. So if you're going to use a Likert scale, that's fine, but make sure that it actually fits what you're trying to measure. And the way that you'll know whether or not it fits what you're trying to measure is if you're able to define the measurement itself. So if you're saying, that you're wanting this client to build coping skills, maybe you're wanting to count how many coping skills, then that's a really concrete number. Or maybe you're wanting to count the frequency with which a person uses that coping skill. Or even if you want to do a Likert scale of, not confident to very confident, the client's self-rating of how confident they are in using this coping skill instead of using substances, you could go there. But make sure that you slow down and get specific in terms of defining the measurement. Otherwise, again, just forcing everything into a Likert scale is not successful. Another form of measurement that you can utilize are things like screening tools. There are so many different assessments and screening tools, self-assessments that you can find. A really standard one is the PHQ-9. That's a very standardized evidence-based method for determining whether or not a person is currently presenting with symptoms of depression. It doesn't mean that they are diagnosed with depression, but it's certainly a good indicator of whether or not this person currently is struggling with symptoms of depression. And you could apply a screening tool like the PHQ-9, and then you can take that baseline is the person's initial score on that screening when you first meet with them. So at your assessment, maybe you used this screening tool, or maybe you didn't use the screening tool until your treatment planning session. But in that treatment planning session, you determined that this person's score on the PHQ-9 is a 20. Okay, great. That's our baseline measure right there. Baseline measure on the PHQ-9, the client scored a 20. Awesome. That's really short and sweet. It's really specific and it's really, really clear. And the great thing about those kind of measures is that then it's really easy to track what's next. You can also use like self-report logs as a way to determine a person's baseline measure. This is a random self-report log that I created with a client years ago to just track what it was like a DBT log for using the opposite action technique for their unhealthy urges. This was a person that struggled with self-harm behaviors. I mean, you could turn this sort of a log, this format of a log, into whatever you wanted. It could be a way of tracking the person's use of particular coping skills to manage triggers to use a substance. It could be attempts to use a certain kind of communication skill. It could be a lot of different things. It could be a person just keeping a log of how often they proactively engage in self-care. This is a really clear way that not only can you then determine a baseline, but then moving forward, you'll be able to track that measurable outcome and goal. And the measurable outcome and goal is how you and the client will know that the need has been resolved, or that the goal has been achieved, or that the client is at least making some sort of a progress towards their goal. So if you had identified that the clients, that you want them to be able to identify 10 triggers, and their baseline is that they can identify like 2, then their measurable outcome or goal will be when they can identify 10. And this is where, in terms of the written format of the objectives and the treatment plans, it is kind of repetitive, because remember, you're writing one objective for each focus need. So you're just addressing one need in that objective. And in that objective for that one need, you're just identifying where's this person starting out, how will we know that they're doing better, and then how are we going to help them get there? Measurable outcomes are super awesome because they're so clearly linked to that baseline measure. The second you have a good baseline measure, you'll know what your measurable outcome is. And conversely, if you're able to think of how am I going to measure this person's progress, then you'll automatically be able to know what your baseline measure is. Because if I'm going to measure this person's progress by seeing how often they do something, then my baseline is going to be how often they do it now. The two are very closely related. What is really fun about baseline measures and measurable outcomes is that it is such a concrete way for you and the client to practice tracking their progress and identifying how they're doing. Now, not only is that super useful in terms of just boring things like documentation, but it also really gives you and the client direct, active, constant feedback about whether or not treatment is working. And if they're not making progress, then you can kind of go back to the drawing board and be like, what's going on here? Do we need to take another approach? Do we maybe want to focus on something else entirely right now? Do we need to look at another way to measure this? Are we not measuring your progress in an effective way right now? In watching a person make progress, it's such great positive feedback for the client and for you as the provider to see, like, yes, we are making progress. This is what we are accomplishing in sessions together. And so in the example of using a screening like the PHQ-9, if we say that the client's baseline measure, so at their initial assessment or when you first sat down with them for treatment planning, let's say you determined that their PHQ-9 score is 25. So then based on that, what could their measurable outcome or goal be? We would want it to be lower, right? So then we would think about, okay, what's a reasonable score for this person to work towards? Do we want to set this person up for failure and aspire for perfection and saying that their measurable outcome will be a 0? Probably not. But the picture of this is kind of blurry. But if you're not familiar with the PHQ-9, it lists like these different symptoms of depression. And then the person rates it as not at all, several days, more than half the days, or nearly every day. If a person scored a PHQ-9 of 25, then it means that they're experiencing pretty much all of these symptoms nearly every day. So I would think that a person is making significant progress if they're only experiencing those symptoms, but either not at all or several days. A 9 would mean that they're experiencing each symptom several days. So I think it would be reasonable to say, let's aim for a 9 or under. You and the client can kind of identify how often do we want to retake this to determine how you're coming along. Maybe this is something that you just retake every month. Maybe it's something that the client's retaking every single time you guys meet together. If it's a little questionnaire screening tool that you implement, it could be something that in theory you apply at the start of every single session that you have together. And that could just kind of be part of your routine. You answer these 3 questions about their self-esteem, and then you dig into your session. And over time, you have this interesting list of scores that tell you whether or not the client's self-esteem has improved or not. It's a really good way to then monitor progress, which is the next component of the objectives. When it comes to monitoring progress, we're asking how will the counselor or the client know that this is achieved or resolved. If our measurable outcome and goal is a lower score on the PHQ-9, then we'll know that this is achieved and resolved by a lower score on the PHQ-9. And we'll know this by the client completing the PHQ-9 in session with me or once a month or something like that. So you're kind of just thinking through the whole idea of how am I going to measure this and see progress being made. Then we're identifying what is the client going to do to get there. So this could be that the client is learning new coping skills to manage their depressive symptoms. Maybe this client is practicing proactive self-care, and we're hoping that that in turn will decrease their symptoms of depression. What is the client going to be doing in session with me and in between sessions when they're like doing their homework or just practicing out in the real world? What are they doing that's going to help us work towards that goal or objective? And then clinical actions and interventions is simply the strategies or the modalities, the techniques, whatever it is that you as a counselor are committing to employ to accomplish this goal. And so this piece, it is important that we slow down enough that we're not just copying and pasting, because the clinical actions and interventions are not going to be the same for every single objective. And they're certainly not going to be the same for every single objective for every single client. What you do in one session with one client may look similar to what you do in another session with another client, but it also may not. And it may vary widely depending on what works for that person. For example, a person who would benefit from a lot of psychoeducation, maybe you're going to be providing quite a lot of psychoeducation and maybe even some assigned reading and things like that. Certain clients are going to respond better to CBT versus DBT. So it's going to vary. If you determine that something else ends up being a more effective approach, that's fine. And you'll simply reflect that in the next time that you update the service plan. You want to be somewhat specific here, but you also don't have to then feel like you're completely limited solely to what you put in there. When it comes to what services you're actually prescribing, you are pretty much obligated to deliver what it is that you prescribed. And the only real reasons why we may not deliver what we prescribe is if the client doesn't show up and participate and do their part. But otherwise, it's our responsibility to make it available to the client.
What if the needs change?
Great question.
Do you wait until a service plan review or do an addendum, or?
It kind of depends on how they have changed and how significantly they've changed. Either the needs have changed a lot and these are new needs that you haven't previously accounted for. In a situation like that, you're going to want to go ahead and complete an assessment update. It can be really short and sweet, but you want to show that the client's situation has changed, that the needs are different. And then you'll update the service plan based on that updated information. And so that may result in a different treatment objective or changing what kinds of services you're prescribing or the frequency or something like that. If it's not that the needs necessarily changed super significantly, maybe it's more that like the person's priorities changed or their buy-in to something has changed, or just for whatever reason, the importance of one need has become higher than originally expected. In those circumstances, you wouldn't need to go ahead and do a whole new assessment update, but you would go ahead and complete a service plan review and update. So you would go ahead and update that service plan with the client, indicating maybe what progress they've made so far or none, and then what you're doing instead now and why. Because humans are ever changing, so are our service plans. And a client does not absolutely have to approach their service plan like a checklist in order to successfully complete treatment, because a person's needs change. And what we think it's going to look like when the client has accomplished their goal may not end up being what it actually looks like when the client has accomplished their goal, right? So for example, with the PHQ-9, this client struggling with depressive symptoms, and I say that I'm confident that this client will have achieved this objective by the time their score is a 10 or lower. What if the client's always at an 11? Does that mean that we have to keep them working on this service objective for the duration of their treatment? Maybe they really are struggling and needing continual work and focus on that objective. Or maybe an 11 is a really good score for them and the client feels good about an 11. And maybe what goes along with that 11 is that this client has experienced a significant decrease in their depressive symptoms and just doing better. And now let's focus on something else in their service plan. they never got to attend, that doesn't mean that they didn't accomplish their goal. They totally accomplished their goal. We don't have to be super rigid. And this is where we want to really be considering client input and feedback. If we're not treating something, we may very well be referring instead. So we've identified this list of needs that a client presents with, and we're going to treat some of those needs with objectives. And then there are other needs that we're not equipped to handle, or maybe we just don't have the bandwidth to respond to right now. And so we're going to refer those needs out to somebody who's better equipped or more able and ready to address that need for the client. Couple of things about referrals. A good service objective, treatment plan objective, does not involve referrals. Referrals are separate. So something that I've seen in plenty of service plans is when a provider will actually write a treatment objective for a client to set up services with someone. That's not a treatment objective. That's a task. That's a task associated with a referral. So us sending a client to an outside mental health counselor, us sending a client to the dentist, anything like that, that's not a treatment plan objective, but it is a referral, and it's a great one. Those are referrals that we're not providing any service around it aside from some basic case management of making sure the client is able to access that service if it's one that they choose to follow through with, right? In Dr. Cloud, how we document the referral, so in your service plan, you list at the end of the service plan what your referrals are for, but then you can actually document when you've made the referral in Dr. Cloud. Under clinical, there's actually a tab called referrals. And if you click on that, it'll bring up the client's full list of referrals that you've ever entered in their chart. And you can create a new one by simply clicking add, and then it will allow you to provide some information about who you're referring the client to and why and what for. And then in terms of deferring needs are the things that we're just kind of holding off on until later. Maybe these are things that we're going to address later in treatment. Maybe these are things that are going to be addressed much later in treatment, even in a lower level of care. Or it might be something that, is dependent on something else happening first. Like maybe the client isn't going to be ready to work on their communication skills with their partner until they've first been able to manage self-soothing when they're super anxious. Or maybe it's that we're not going to work on couples counseling until the client's partner's work schedule has changed and they'll be available to participate in couples counseling. So depending on what the person's needs are and what you're prioritizing, then you may be deferring something until later in treatment. Those are the things that you may then revisit after the client has accomplished something else. So this client with the PHQ-9, yay, they're at an 11, and we feel like an 11 is a good place for this client to be at consistently on their PHQ-9, and we're considering that objective resolved. Now let's look at something that we had previously deferred in Dimension 3 and address that now. So this table does live in the documentation handbook. When you're creating your service plan in Dr. Cloud, as long as you select the level of care accurately in your plan that you're setting up, the options for prescribed services will be customized and limited to the right categories. So you'll notice, for example, that if you're creating a service plan in residential, it will give you certain options that are not visible in the service plan if you select a 1.0 outpatient service plan. But then you'll see that, there's still some flexibility. There's still some room in terms of how much you're actually going to be prescribing. And so that's going to be based on what you and the client determine that they need. Now, discharge criteria is identifying how we'll know that the client is ready to move on to a lower level of care. Examples of insufficient discharge criteria are things like the treatment will be complete when the client has met their goals. If you're thinking about treatment in terms of medical necessity and what is going to justify this client receiving treatment services with us, how will we then know that they don't need that treatment anymore? We'll know that they don't need that treatment anymore because they will have probably attained some kind of higher level of functioning. They probably have experienced reduced symptoms. And so if we think about what the client presented with that qualified them for the level of care that we're treating them at, then their discharge criteria will be that they no longer meet that, right? If it's too vague, then we wouldn't be able to determine that from just a monthly review. We'd be looking at this client's treatment and be like, oh gosh, you've made so much progress. Let's revisit your discharge criteria. It's kind of vague. I'm not really clear on what is expected in order for you to be done. A client's ability to consistently withstand substance use outside of a controlled environment, as evidenced by consecutive negative UAs, and client's self-reported ability to manage their triggers effectively. Maybe this person's attainment of higher level of functioning is evidenced by their ability to consistently cope with triggers rather than resorting to substance use. Similarly, is this client able to maintain whatever this higher level of functioning is without the added supports that you currently have in place for them? And so those are the ways that we would look at discharge criteria. In terms of how it's written, you don't have to fill in every single sentence stem. The way that the service plan is displayed in Dr. Cloud, it kind of gives you a few different sentence stems to prompt you. And so you should certainly complete at least one, because doing so will give you some specifics to point to and say, this is a good, reasonable discharge criteria for this client. Discharge criteria should be specific. You want it to be specific to that client. It can be a general statement like ability to cope, but what is specific to that client? Like, what is it that they're struggling with, and what will it look like when they're not struggling with that anymore? And again, it's important to think about, is this linked to medical necessity? Like, could I justify to an insurance company that yes, this client does need this level of care still? And usable in terms of, if a client goes up to you and says, when can I be done with treatment? Can you point at their service plan and say, let's look at it together. Let's look at your discharge criteria. If you look at the discharge criteria with your client, will the two of you be able to walk away from that conversation on the same page about what things will need to look like in order for them to discharge? Or is it kind of vague and therefore not usable? So this is a screenshot I took of the chart audit tool in Dr. Cloud. Definitely recommend going in and opening up a clinical chart audit in Dr. Cloud for one of your clients, or you could just do that under a test client if you want. The Encounter is available under the test facility or under the On-Track Rogue Valley facility. This is a really good way to kind of look at, are our service plans adequate? Are they addressing what we intend for them to address? So if we can say yes to these different things, then we know that, okay, this service plan is meeting the requirements and is probably usable to both the client and the provider. So we're wanting to know, in your service plan, are you appropriately referring, deferring, or treating the needs that you identified in the assessment? A big one is, are the components of each objective specific, individualized, and do they make sense? So individualized as in they are not copied and pasted and identical to all of your clients' treatment plans, which, by the way, is super obvious that you've done if your objective then has the wrong client's name in it. At least, guys, fix the client's name if you're going to copy and paste. But better yet, don't copy and paste. So we want to make sure, right, that it's person-centered. Obviously, some clients are very similar, and two clients, you may very well rightfully give two clients the same treatment objective. Fair enough. but not every client is going to have the same treatment objective. And there's going to be slight differences, probably, especially when it comes to their baseline measure and how you're going to measure the outcome. And then in terms of it making sense, this is where we go to that, if we're measuring the baseline measure and measuring progress and things, is it logical? Does it make sense why we're like, am I attempting to measure progress towards learning coping skills with a completely irrelevant Likert scale that makes 0 sense? Or are we tracking it with like a self-report log that, sure, that makes sense and would be easy to track and follow? It doesn't have to be this like masterpiece of a treatment objective, but we want it to make sense. It should be simply doing what we intend for it to do. We're also going to want to make sure that we are prescribing the right amount and intensity of services depending on the level of care that the client is placed at. And then again, making sure that those services we're prescribing are appropriate for that person. So that would be the example of like, if this person has severe ADHD, I'm not going to prescribe them to 60 minutes a week of counseling with me. I'm going to break that down into shorter sessions. Making sure that your prescribed services include the correct frequency of UAs and treatment team meetings and service plan development and case management, and that you're prescribing care services when appropriate. Basically all of those prescribed needs that are, or prescribed services that are listed in that table I showed you. And then also, is the plan signed by the counselor and client? And is it in general thorough and complete? Remember that even though the way the objectives are written is kind of obnoxious, the plan should still be clear and concise enough that when you give it to the client, they understand it and agree with it, and it doesn't look like complete news to them. Also, is it in client-friendly language, and maybe language that the client themselves has used or would use to describe what you guys have talked about? And so if we're looking again at that golden thread, we're tying the assessment needs into that treatment plan. The treatment plan is informing the services that we're then delivering and documenting. And then at whatever frequency is required, we're reviewing how it's going and making changes and updates and revisions based on what the client needs. And so depending on the level of care, we're going to be updating the plan every 30 to 90-ish days. And we're going to, in that treatment plan review, to look at what progress the client has made so far. So you're looking at those treatment objectives that we wrote and say, okay, this was your baseline. What is your measurement now? Is that progress? If it's no progress, why is that? Is something not working? Do we need to revise something? Maybe they've made significant progress. Great. Are we ready to move on to something else? Or do we want to continue to focus on this because there's still room for improvement? What do we want to do next? How are we going to proceed in order to ultimately achieve that discharge criteria? And this is really when you have a clear opportunity for refocusing your needs. So you may find that the client made some progress toward their objective, and in the meantime, something significant changed and their priority has changed. And so rather than continuing with this objective some more, maybe we're going to implement a new objective and focus on this other need instead. That's perfectly fine. That's going with the flow. That's adapting based on what the client's current needs and presentation is. This handy table is in the documentation handbook on SharePoint. It simply identifies how often we are supposed to review a service plan based on level of care. And this is really like the minimum frequency, because if a client's needs significantly change, or you and the client just decide together that you want to check in and review and update things, you can do that more frequently than is listed. But at minimum, we should be reviewing it 30 days of intake, and then every 60 days thereafter for 2.1 and 2.5. Whereas in residential, we're conducting it within 2 weeks of intake and then every 30 days thereafter. So do spend some time looking at this chart that's in the documentation handbook. It might even be helpful to like print it out and tape it somewhere, just because it's a really good way to kind of keep track of how often you're supposed to be reviewing things with different clients, especially for those of you in outpatient with clients that are in different levels of care. And then just to make life somewhat easier, this second table just outlines how you would document or select the encounter for your service plan review. So depending on what plan you're reviewing, the facility you select may be a little different, and you'll want to make sure that you're selecting the correct service plan that you're reviewing. So when we're reviewing and updating that plan, we're simply looking at, okay, the progress that they've made and checking in on, is there something new that's come up that's taking priority now over what we had previously prioritized? And again, what progress did they make towards their objectives? And do we want to continue with that objective or replace it with something new? And this is an opportunity again to kind of revisit, what are you treating, referring, or deferring? You don't need to keep plugging in an old referral. Once you've made that referral, you've made that referral. So maybe there are new referrals to make, maybe there aren't any. And then there are other things that you're probably going to be prioritizing in treatment, and probably other things that you're still going to continue to defer or just, press the pause button on. This is, again, a screenshot from the chart audit in Dr. Cloud. And so these questions are specific to the service plan review process. So if you're ever thinking about, am I doing a sufficient service plan review? You can look at these questions and kind of check them off for yourself. So in your service plan review, is the client's progress toward their current objectives discussed? Like, did you kind of give a summary of their progress and whether or not they've accomplished those identified objectives and goals? In your service plan review, if the client completed some of their objectives, did you go ahead and replace that with a new objective or address other needs in the domain? Or did you indicate that they did successfully complete all of their needs and objectives in that dimension and you're ready to move on? Basically, is there a clear story and follow-up in that service plan review? In the service plan review, do the needs for each of those current objectives match the needs or elevated risk in the client's assessment or assessment update? So if you did update the client's assessment because something significantly changed, does their service plan review's new objectives match that? Like, are you adequately addressing the new elevated issues with new objectives? Or even if you didn't complete an assessment update, simply are you prioritizing the right things with the client based on what you originally determined that they need and based on what they are sharing with you they need today? Again, with the service plan and the reviewed and updated version of it, are the components of the objective specific, individualized? Do they make sense? If there are new referrals, are the referrals there? Do they make sense? And again, are you continuing to prescribe services that match the level of care? And so if you're saying this is what the client needs, are you setting them up for success? Are you giving them the right plan that will allow them to get that need met? And so we can continue this process for as long as we need to until the client has accomplished what they've set out to accomplish. We're going to keep reviewing and updating that plan and proceeding with the services that we've prescribed until we find that the client has successfully met the goals that you identified with them, at which point you can proceed with discharge. So really quickly, and then we'll go ahead and wrap up. I want to clarify a couple of things about ICOD, especially for those of you in outpatient, because this can get a little bit confusing for people. So if we think about, the integrated co-occurring assessment is going to be identifying what the client's needs are, and then you're presenting a treatment plan. The thing about an integrated co-occurring service plan and assessment is that they have to be signed by a QMHP. You can contribute to or help create that ICOD treatment plan, but it does have to be signed by a QMHP. And if the QMHP is late to the game, so maybe you already started like an A&D service plan with the client or something, rather than starting all over and starting from scratch, the QMHP can add on a mental health addendum to the service plan to transform that A&D service plan into now an ICOD service plan. So that's a solution rather than going back to ground zero and starting over again with a whole new initial plan. Is simply adding on to your existing A&D plan with mental health objectives to match what the QMHP identified that the client needs that are specific to those mental health needs. So this is more FYI, but it can be helpful to see so that you understand how your services interact with QMHP delivered services. ICOD stands for Integrated Co-occurring Disorder. So if we're providing ICOD services, we're providing integrated services. So we're trying to get the A&D and the mental health needs to be all addressed in the same plan, under the same roof, with the same overarching goals and needs, right? So even if you're divvying out who's delivering which component, maybe, as a KDAC, you're delivering the A&D stuff and a separate QMHP is delivering the mental health stuff, you two are still working towards the same goals and are addressing the same overarching goals, needs, and so on. And so that's where you then are addressing that from the integrated assessment. And so if you're working with a client who is in A&D and mental health or ICOD, then you're going to be treating them under this integrated service plan, an integrated co-occurring disorder treatment facility. Whereas if this client was just in mental health services, then you're not really going to be interacting with them much at all, if at all, and the client is just going to be receiving solely mental health services from their mental health counselor. So that's it. Hopefully there was some useful information there of a refresher. Any final questions, thoughts, anything that needs clarification? We do have time.